Hi, my name is Madeline Spencer, and I will be presenting to you today on community and school-based health centers. All right, so the particular policy that I was assigned is the Community Health Centers and School-Based Health Centers policy, and that is part of the other investments section of the Affordable Care Act, which was enacted on March 23rd, 2010. Um, So beginning the fiscal year 2010, $14 million was allotted for school-based health centers and $15 million for nurse-managed health clinics. And in 2011, there was an $11 billion increase for community health centers, as well as a $1.5 billion increase for the National Health Service Corps. All right, so the problem here before the enactment of the Affordable Care Act was that there was a lack of access to care for many Americans, specifically children and low-income disadvantaged adults. And so there was a lot of income inequality, and there was a high cost of healthcare services and insurance in America. And without proper healthcare and access to proper healthcare, a large number of people face health disparities, which inevitably leads to a less healthy workforce, which eventually leads to economic problems. Children, as they say, are the future. And if the health of our children is not addressed as soon as possible, we are setting them and our country up for failure. All right, so what benefit has the population received from this policy? The affected population has received improved access to care, a reduction in health disparities, and greater quality of life. And this could be measured with a number of different measures, but the specific ones that I pointed out are satisfaction with services provided. You can measure blood pressure, diabetes maintenance, depression, or wait time for in-office appointments. And according to the Health Resources and Services Administration on Affordable Care Act nurse-managed health clinics, the purpose of the policy is to provide health services to medically underserved and or vulnerable populations, regardless of patient insurance status or income. And so this policy addresses fairness of resource allocation. And as for cost, I have not yet found studies on cost benefits of this policy, but for the policy to be administered, an application has to be completed. And if an entity met all the requirements for the funding opportunity, a grant would be given. And so a measure for that could be how many entities total were awarded grants. And then finally, grant funds can be used for hiring employees for these new health centers. For the stakeholders category. One way that it could be measured is how many new employees were hired with these funds. All right, so a benefit to this policy is that it expanded health services for children and economically disadvantaged Americans, which reduces health disparities and improves quality of life and access to care for a greater portion of the population. And then a deficiency is that it doesn't cover everyone. Ineligible immigrants are still unable to receive care through this policy. And if this portion of the ACA were repealed, fewer people would receive healthcare because they would lose access to these healthcare centers. An alternative for improvement in the current policy is that you could prepare these health entities to move away from volume-based reimbursements. And that would benefit pretty much everyone involved, almost everyone involved. Less would be spent on unnecessary tests, treatments, etc. And people would not be forced to spend more on what is actually unnecessary, and therefore is a better they receive a better value for their care. And since value-based payment systems have begun to be implemented in other health entities, preparing these specific entities that are part of the policy to switch from value-based payment systems to value-based systems would be very possible to achieve. And so that is all I have. Thank you so much. Here are my references. Have a great evening.